পারেন, তারপরে আমরা শুরু করব।
হ্যাঁ হ্যাঁ, শোনাচ্ছি।
জি, শোনা যাচ্ছে।
তাহলে একটু শুরু করতে চাচ্ছিলাম।
জি।
শুরু করবো।
Yes, you can start now.
Good evening. I am Dr. Chaudhary, one of the doctor here in this outpatient clinic. Am I speaking to Mr. Smith, 56 years old?
Yes, doctor.
So, Mr. Smith, today we are going to discuss about your health condition and management plan. Is it all right?
Yes, fine for me.
And during our discussion, I may take some note, and I ensure you that whatever we discuss, that will be very confidential between two of us.
Okay, that's fine.
So, Mr. Smith, I can see that you have some weakness. Would you please tell me in your words what you mean by that?
Oh, doctor, for last 8 hours, I have some weakness develop in my uh, right hand, and for last 4 hours, I also think my right leg gets weaker. So initially, it was not that bothersome for me, but later on I find that I am not able to grip anything on my hand, and I can even hold a cup on my right hand as well, and that's quite frightening for me, and that's why my daughter and I rushed to hospital whether I am developing any sinister thing.
Okay, so is it the first time, or this kind of thing happened previously?
No, doctor, it's the very first time I'm experiencing this type of symptoms.
Okay, so by weakness in your hand, you mean to say that you can grab anything. Can you raise, are you able to raise your hand?
I can raise my hand, but it's weak.
Okay, and you said your weakness in leg. Could you please tell me more about your leg weakness?
So, uh, how can I explain? It's difficult for me to take a step, but I can take a step, but I feel weaker on my right leg.
Okay, are you able to stand up and walk?
Yeah, I can.
Okay, is it very difficult to walk right now?
No, not much.
Okay, so you tell me that it's happening for last 8 to 4 hours, and is it progressing, Mr. Smith?
Yes, doctor, I can say that. I think my weakness getting worse.
Is there any kind of other problem that you are facing with your weakness in your hand and leg?
No, I don't.
Okay.
You mean my other part of my left hand, my left leg? That's are
any
fine.
any kind of other vision problem or headache that it might be?
No, no, no problem with my vision.
Oh, okay, so is there anything that is making worse or better?
No,
Okay. So, Mr. Smith, I'm going to ask them some personal question. Do you have any kind of past medical history that I should know about, such as high blood pressure or high glucose?
I have both of these. I have high blood pressure for last 10 years. I have high blood glucose for last 5 years.
Okay. So, can I see your medication chart, Mr. Smith?
Yes, patient is showing your medication chart. Patient taking Remipryl for last 2 years, and patient is
Remicade.
on, yeah, patient is on insulin, uh, mixed type of insulin, which he is taking twice daily.
Okay. So do you have any problems for your blood fat? By that mean, I mean cholesterol problem.
No,
Okay. Is there any kind of hospitalization history or any
oh,
blood,
I never hospitalized for any reason.
any surgery or blood transfusion?
No, never.
Okay. Is there any kind of medical condition that runs in your family that you want to tell me?
No, my sisters, my parents were well.
So no such problems such as weakness in your that runs in your family, right?
Weakness is a very specific thing, doctor. No, I don't think.
Okay, okay. Do you have any? Do you have noticed that you are getting calor by day?
No,
Do you have any raised body temperature?
no,
Okay. Do you have any kind of soreness in your mouth or any part of your body?
no,
Mr. Smith, do you have any kind of soreness in your mouth or any part
no,
of your?
no, no, doctor. No,
Okay. Was there any kind of recent weight change, loss or gain?
no, no
How was
change.
your how was your appetite for last few weeks?
My appetite is fine.
Is there any kind of weather preference?
No,
Do you have any kind of headache or vision problem?
no. You asked about the vision problem. I don't have any vision problem.
Okay, is there any kind, you told me that you have weakness, but is there any kind of numbness or tingling sensation in any other part of your body?
No,
Is there any kind of racing or pacing in your heart?
no,
Any chest tightness, shortness of breath, any cough?
no,
Did you feel any kind of lumps or bumps in your body?
no.
Mr. Smith, could you please tell me how is your water work? Is any kind of changes in amount or any hardiness, color?
No, doctor. My water work is fine.
Is there any problem with your back passes?
What type of problem, doctor?
Any kind of change in amount or hardness, hard stool,
No,
or
I didn't notice any change in my bowel.
okay, Mr. Smith. Did when did you last check your blood glucose level?
Oh, my GP is very happy about my blood glucose control, actually.
Okay. So, Mr. Smith, at this moment, I want to check you, and during this checkup, yeah, I will talk, and if you have any kind of problem or pain, you should tell me that I will be very happy to stop.
Okay,
Is it
thank you,
okay?
doctor. Yes, you can. You can.
Okay. So first, I want to see the patient is anemic or not.
No, patient is not anemic.
I want to see I want to see the muscle power of the leg. And is there any kind
Muscle muscle power in the leg is 4 out of 5.
okay, is there any kind of washing or fasciculation, any scar mark?
No, nothing. Nothing on inspection.
Okay, any kind of change in tone, hypertone or loose tone?
It, tone is normal.
Okay, I want to check the plantar reflex.
The plantar is upgoing.
Okay, I want to check the reflex, the ankle reflex and the knee reflex?
Reflex are normal.
Okay, I I want to see the tone of the hand.
Normal.
I I want to see the muscle weakness in upper hand, right hand.
It's difficult for the patient to raise the hand. You can assume the power is about 3 out of 5 on MRC scale.
Okay. I want to see the reflex, the C6, C7, and C5.
Reflex are present.
Is it bricks or normal?
Normal. Normal.
Okay. In this moment, I want to check the carotid bruit. Is there any kind of carotid bruit?
No, there is no carotid bruit.
Okay. I want to see. I want to see the neck. Is there any kind of an anterior neck swelling or anything like that?
No visible neck swelling.
In the same moment, I want to check for any kind of cervical lymphadenopathy in the neck.
Good. No.
Okay. I want to check the precordium. Is there any kind of abnormal heart sound?
Examiners say you don't need to proceed for precordial examination.
Okay. I want to see the base of the lung. Is it any kind of problem?
No need to proceed for base of the lung examination.
Okay. In the end of my examination, I want to finish with fundoscopy and urine dipstick.
Okay.
Okay. Is there any vision problem?
No, I say to you, doctor, I don't have any vision problem.
Okay. Okay. I want to check, is there any kind of edema in leg?
There is no edema.
Okay. Mr. Smith, I want to ask you some couple of questions. How was your mood in past few days?
My mood is fine.
Okay. Do you follow any kind of strict diet?
No.
Okay. Mr. Smith, do you smoke cigarettes?
Yeah, doctor, I smoke. I do smoke.
I think Mr. Smith, the smoking is injurious for health. If you, I advise you to stop smoke. If you want, I can refer to a smoking cessation clinic.
Okay, thanks for the reminder.
Mr. Smith, do you drink alcohol?
Oh, I'm an occasional drinker, doctor.
Okay, is it in social limit?
Yeah, I do.
Okay. Mr. Smith, do you drive?
Yes, I drive.
Mr. Smith, as you have weakness in your hand and leg, I advise you to stop driving in the current moment until we reach a diagnosis, and we will tell you further what to do. Mr. Smith, do you what kind of job you do?
Oh, I was a school teacher, but I recently retired from the.
Okay, sir. Do you have support at home at this moment?
Yeah. I live with my kids, and I'm supported.
Mr. Smith, now tell me what are your concerns, Mr. Smith?
So, doctor, why I'm having this weakness, and what do you think? Is it something serious?
Mr. Smith, I think that you are having a medical condition. It's called transient ischemic attack. Don't bother about the medical term. It's a thing when blood clots in our blood vessel of our brain, and it causes some weakness in our hand and legs. Are you
Okay.
getting me, Mr. Smith?
It sounds like a stroke, isn't it?
Yes.
Okay. So it's very serious, doctor.
Yeah, any kind of stroke could be serious, but I'm not. The thing is that you came to the right place, and there are treatment available, and we will treat you as soon as possible.
Okay, thank you very much, doctor.
Is there any other concern that you want to ask, Mr.
No,
Smith?
thank you.
Mr. Smith, is there any other thing that you have, like weight loss or night sweats or any kind of jaundice?
No, I didn't notice any yellow coloration of my eye, and any other symptom you are asking. I am not having any of those.
Okay, Mr. Smith. Now we will admit you today in our hospital, and we will do some scans of your brain and some blood test. And following that, we will start your managed treatment immediately. Is it all right?
It's completely fine.
Okay. My 13 minutes are finished, Bhaiya.
So, okay, you can finish now. You have 30 seconds left. Okay. So now the examiner question. So, what are your positive findings in history in this case?
Mr. Smith, who is the elderly patient, who is having weakness in his hand for last 8 hours and weakness in his leg for last 4 hours, and he is also hypertensive for last 10 years, and he is diabetic for last 5 years. And though I forgot to check the ask for the observation chart, and
Hmm?
and his planters are upgoing, and
Hmm?
he has some muscle weakness in his right hand, which is 3 out of 5 MRC gets scale. So
Hmm?
all of this combining, my diagnosis is transient ischemic attack.
Okay. So do you have any differential diagnosis?
Yes, it could be just a cerebrovascular incident such as stroke.
Stroke. So apart from stroke, any other differential diagnosis you have?
It could be ICSOL, it could be any kind of, it could be ICSOL, and it could be any kind of electrolyte imbalance.
Okay. And how are you going to manage this case?
First, first I would like to admit the patient into our emergency ward, and we'll do some basic routine checkup for such as CBC lipid profile, and we will do a CT scan of his brain.
Okay.
And following that, we'll proceed to treatment and other investigation.
Okay. For the treatment,
For if could you please repeat, sir?
what about the treatment? What treatment you want to give in this patient?
So if you don't find anything subtle in the CT scan, so the TI is
Scan is
contrast.
normal. CT scan comes normal.
CT scan comes normal, then I want to follow the treatment strategy of transient ischemic attack. I want to give 300 mg of aspirin as soon as possible, and
Okay.
then
Is it possible? Is it possible to CT comes normal in a stroke patient?
yes.
Okay, we can conclude the examiner question. Doctor, what's your name, please? Sorry,
My name is Dr. Shid Chaudhary.
Dr. Chaudhary. You done quite well, uh, but from the history, from the history point of view, uh, you asked about my name. Your introduction was fine. You said that our discussion will remain confidential. You give me reassurance. But at the very beginning of the station, I was very frightened that I, I said you that I am concerned, very concerned that I might develop a sinister disease or something dangerous. So whenever your patient is very concerned, you should give him or her some reassurance. You can say, "I understand you are very concerned about your symptoms, and I am here to help you, and I will do my best to help you today." Some kind of promising word from the doctor would be very helpful in this type of situation in real life and even in exam. If you say these words in your exam, there is a very high chance you will score very good number in your uh, communication skill. So these are the skill they are looking for, whether you have any sympathy, empathy, or you are identifying the concern of the patient. So ignoring it, omitting it indicates you are not getting it properly. So then you asked me what brought me here today. So I explain you that I have weakness. You asked a very important question, whether this is the first time. This is a very important question for all our listeners. For any symptoms, we need to ask about whether the symptoms patient develop for the very first time, because uh, patient may have several episodes of weakness that will go to a totally other territory. If patient say that I have on and off weakness in my right hand, sometime I also develop weakness on my left hand, and I have mild form of weakness on my left foot, and I still have some weakness on my right leg. So multiple type of weakness in multiple time space, where it's going. So is it the first time you are experiencing this type of weakness? This question is very important. And then the timing of the weakness, when you smell, it's one-sided, it's lateralizing. That means it's one-sided weakness. It's a very important clue that it's until clue, otherwise it's a stroke. For within 1 minute you smell, it's a stroke. So you have to ask you already asked a question which was a very good question, that whether I am still having weakness or whether this weakness is increasing or decreasing. So if the patient have weakness and the weakness is gradually worsened, is it TIA or is it a stroke? Is there any way to differentiate between transient ischemic attack and stroke, Dr. Choudhury?
That TIA symptom resolves, but the stroke symptoms increases. There was some mistake from my side.
Okay, we can correct our mistake here. So that will not be a mistake anymore. So that's why we are here. So we will do mistake when we will correct our mistake. So the definition of transient ischemic attack, there will be no neuronal damage. There will be no permanent neuronal damage, which you can find in MRI or in MRI scan specifically, and the symptom will be resolved within 24 hours. And in case of stroke, the symptom will persist. So initially, you can't say that it will resolve within 24 hours. That's why it's very difficult to comment whether it's TI or a stroke. If patient still have weakness and weakness is progressing, it's a stroke. So you have to take it as a stroke. And we have window period for stroke treatment. So time is very important. In heart, we say the time is myocardium. In neurology, we say the time is brain. So for every 30 minutes, we may lose about 3 million of neurons. So we have a window period for early thrombolysis therapy. You know it. That is the 4.5 hour. So timing is very important. Sometime when you got a stroke, very earlier part of your examination, within 1 minute or 2 minutes, you can even ask the examiner that I am thinking about a stroke and I want to take history and examination as well as giving management to the patient. I am telling you a secret. It's not a secret, but just to perform very well in PACES consultation station, you need to be a actor. You need to be an over actor. Suppose this patient is surrogate and the examiner want you to act, and you will make the exam environment like a movie theater. You are performing acting, and you have to act. You suppress the acting of the surrogate. You make it like real patient, and you make it like real environment. So when a real environment, a real patient comes, we can't wait to take the full history and full examination, waste 20 minutes just to take history and examination and wait for giving thrombolysis therapy. It's not happen in real life. So you make it a real life scenario that will be very helpful. So I can tell you two conditions which are very commonly appear in PACES exam, especially in clinical consultation exam. One is the ischemic heart disease, the myocardial infarction, the acute coronary syndrome, and the number two is the stroke. So when you smell, it's myocardial infarction. Patient have chest pain. They give you some vitals. The saturation level is 90. The patient tell you that the pain is going in favor of myocardial infarction, and this is pain scale is about 7 or 8 out of 10. You have to mention this examiner that I am thinking about acute coronary syndrome. I want to take history, physical examination, as well as managing this patient. It will make you a safe doctor, the safest doctor. They want the safest doctor. They want the safest pair of hand. So remember this thing. This is a trick to be a safe doctor in exam. So you ask about this question, and later on, so we usually follow a protocol, but don't too much strict on a single protocol. Like you say, is there anything make it worse or make it better? Is there any importance of this question in this stroke patient? No, you know it is stroke. So after confirming this patient have weakness on his right hand, weakness on his right leg, go for the stroke questions. What are the stroke questions we ask in a patient, Dr. Chaudhary?
We take is personal history, drug history, and medical history first, then the progression of the weakness and family history.
Okay, we ask about the progression. What other symptoms you find? Once you confirm it's all develop all on a sudden. Until proof otherwise, it's a stroke. You know it. So what other symptom you want in this patient from head to toe? You got my question, doctor?
Any kind of speech or vision problem that please guide.
Okay, you can start from the eye. You can start from the eye. What you already asked, whether I am having any vision problem, whether I am having any double vision. Then go to the mouth. Do you have any problem with your speech? Do you have any problem with your with swallowing or difficulty in taking food? Do you have any problem speech? Then go down the hand and feet.
Waterwork and bowel process also.
You can ask. You can also ask about the sensation. Stroke, there may be hemisensory loss. So any problem with sensation? You can ask about the balance. Very important question. Do you find it difficult to work or find it difficult to maintain balance? Very important question. Other question for differential diagnosis. For differential diagnosis, you need to ask other question like headache. It's very important here. Do you have any headache? Do you ever lost your consciousness? Any shakiness? So one more thing. So when you ask the symptom of stroke, after screening of all the symptom of stroke, you need to drive to the neurology system. So here systemic analysis, what we usually done in later part of the discussion, like after completing the most of the history, we can take the neurological screening question a bit earlier in this type of scenario. Like after asking the weakness and all other symptoms of stroke, you can ask about the other neurological symptom. What other neurological symptom you can ask? The dizziness, the loss of consciousness, the shakiness, and the risk factor for stroke. Always ask about the risk factor earlier. So whether I am having any high blood pressure, high blood glucose, you ask about the cholesterol and smoking habit. For younger stroke, what specific question we need to ask?
Any family history?
Good. Anything else? For younger stroke, ask about the clot problem. Very important. If it's specifically for female patient, ask about the pregnancy loss. Very important. For examination, what we examine in a patient with stroke, So you started your examination by checking anemia. Do you think it's good?
No, it
No.
looks and sounds bad.
Never, nowhere in PACES exam in long case there is no station where you have to start unless it will be very rare like celiac disease. You can start your examination by checking anemia. So apart from that, I don't think there are any other station where you have to start your examination by checking anemia. So always try to start your examination from the hand. Always, whatever it is, start your examination from the hand, then go to the head and then go down. So start
Okay.
that. What do we do? What do we do in clinical session in respiratory medicine? What do you do? You check for claving, you check for the pulse, then you go up, then you go the eyes, then you check the sinuses, then you go down in the chest. So like this, always start at your examination. If you can't remember anything, just check pulse and remind yourself, recollect yourself what you want to examine. Sometimes it's happened like you just going to a blind mode and you start checking jaundice. Not like this. If you are in a blank mood, so touch the hand of the patient, handshake with the patient, check the pulse, and think what you can examine in a patient with stroke. That will give you time and give you a very good impression. And you are getting 10 seconds of time to check the pulse and uh, uh, collect yourself what you can examine in this patient. So pulse, I am saying pulse is very important here. Stroke, remember this thing for rest of the time unless you pass the PACES exam. Stroke means two P's, pulse and plantar. The more the plantar, how much important is plantar for a patient with stroke? It's very much important, like this. In 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 a long case of stroke, in a PACES station, unless unless you exclude atrial fibrillation, the case will not complete. So they love atrial fibrillation. You have to check the pulse. You have to check the pulse. So you can start it from the pulse, or I used to start it by checking the pronator drift, which is the standard of examination. It's in the guideline for every patient with stroke. You have to check the pronator drift. What happen in case of pronator drift? If a patient have a power of 3 out of 5 or 4 out of 5, that will bring the pronator drift. The pronator drift will bring the subtle weakness, uh, help you to find the subtle weakness. The supine position hand will get pronated. So you can start it by taking the pronator drift. Raise your hand like this in supine position. Palm is in supine position, and you have to watch whether there is any pronator drift or not. Then go for the pulse examination, and then go for the power. So we don't need to check the whole range of power examination here. You can check the elbow power here, elbow flexion, elbow extension, and the shoulder power. And then up in the head, you can check the facial nerve. So every case of stroke, you need to screen the facial nerve, because facial nerve is very commonly affect in case of stroke. So what examination you want to do just to screen the facial nerve in long case?
I want to ask for to smile, to blow his mouth, and
Okay, so you can do three tests, just three tests. Raise your eyebrow like this. You have to do like this for the patient. Raise your eyebrow like this. You have to do this thing and ask the patient to do like you. Raise your eyebrow like this. Show me your teeth like this, and puff your cheek like this. These three. End. And then in the neck, what do you check in the neck? The carotid. Excellent. Carotid. You need to check the carotid. But for carotid examination, what do you instruct the patient to taking the carotid? What do you want to check in carotid?
I want to check for carotid breath.
Carotid breath. Anything else? Do you want to check the carotid pulsation here?
I want to check the any kind of tenderness like that.
No tenderness. Actually, we look for the carotid bruit, only carotid bruit. So for carotid bruit, ask the two permission you need to take. Two permission. Number one permission is from the examiner, and number two permission is from the patient, and ask the patient to hold their breath. So sometime stroke patient may have some sort of carotid hypersensitivity, and there are some feedback where candidate attempt to auscultate the carotid and examiner directly hold their hand not to touch the carotid. Why? Because patient might have carotid hypersensitivity. So always ask the examiner, sir, may I proceed for carotid auscultation? And then uh, tell the patient that could you please hold your breath? I want to auscultate your neck. So you look for the carotid bruit. So what is the importance of carotid bruit? That's indicate you have generalized atherosclerotic change. You have atherosclerotic change in your carotid. You have atherosclerotic change in your brain arteries. So after that, go down. What do you want to check?
Then I will check lower limb examination.
So just brief, just briefly auscultate the heart, then go down.
Okay.
Just very briefly auscultate the heart and don't go down. So in case of leg, if I give you two options, what two examination you want to do in leg?
I want to do the plantar.
Very good, excellent.
And the power.
Yeah, excellent. These two, yes, these two are very important. And then you can ask the examiner, sir, I want to check the blood pressure, blood glucose, fundoscopy, as well as full sets of cranial nerve examination and other neurological examination. So the examination is very important, but you need to know what examiner wants from you to examine. Examiner, before you enter into the station, before even start the PACES exam, they write down what they want you to examine in a patient with a stroke. So they write down, I want pulse, I want pronator drift, I want power, I want facial nerve examination, I want plantar. So you have to touch this thing. These are very important. And if this patient have if this patient have any vision problem, if the patient may say to you that, doctor, I also have some vision problem. I think I am seeing blur, or I don't think I am seeing properly through my right eye. So in that case, you may need to ask for fundoscopy at a very early part of your examination. So this was important. And for weakness approach, so how many we are here now? So we are here about 12 person. These 12 person are very lucky because I will try to make the weakness approach very easy for you. And if you remember this thing, you will not forget. You will very confident to deal with any patient who presented with weakness. So for weakness, if a patient presenting with weakness, the first question you need to ask, which part or which limb you feel weak? And do you still have the weakness? And the third question is also very important. And in PACES exam, it's a what should I say? It's a script. The surrogate also have a script. So they also write down that this patient have they will instruct the surrogate that you are having floppy or stiffy type of weakness, or you may not have any specific type of weakness. So you have to ask this question: whether do you feel this? Do you feel your limb is a bit floppy or a bit stiffy? So I said you that three question: which part still have weakness, and is it floppy or stiffy? Based on these three things, we will differentiate. We will make our differential diagnosis list. The first differential is monoparesis or hemiparesis, which was the lateralizing sign. So for hemiparesis, we have uh, two categories. Number one is the transient weakness, and number two is the permanent weakness. And we have another category, which is paraparesis. The patient say you that, doctor, I have weakness both of my lower limb. Yeah, this is paraparesis. And another group we have, patient may say you that I have weakness both of my lower limb, and I also have weakness. I also have back pain. So for common cases, according to the common cases of patient, for any patient presented with any limb weakness, we can categorize the patient into three categories. The number one categories is the hemiparesis. Number two categories is the paraparesis. And number three categories is the paraparesis with back pain. So for the hemiparesis, I said you that hemiparesis, we have two categories. The number one category is the transient form of hemiparesis or monoparesis, or there is a permanent form of hemiparesis or monoparesis. So for the transient ischemic attack, if it is a transient ischemic attack, they will not give you a case who still have weakness. So if I say to you, Dr. Chaudhary, if I say to you, I have weakness which was lasted for 2 hours, but doctor, I don't have any weakness right now, but I have all the risk factor in this world. I have hypertension, high blood pressure, high blood glucose. I have family history of cholesterol problem. I'm a smoker for last 20 years. What do you think? What's your diagnosis?
Weakness was lasted for 2 hours. This is
2 hours.
TI.
Good. This is TI. You can confidently say. Don't say transient ischemic attack. It's a very hard term to understand for the patient. You can say mini stroke. Mini stroke is a uh, what should I say? It's a very good term to explain a patient. It's not a full blown stroke. It's a mini stroke. But at the same time, I can say you that it's a serious condition. So mini stroke doesn't mean it's not a serious condition. It's a serious condition, but it's not the full blown stroke. So you have to explain this thing to the patient. Don't say transient ischemic. You can say in medical term we say transient ischemic attack. It's a very fancy term actually, and you don't need to remember this thing. We can simply say it mini stroke. So for transient ischemic attack, for transient hemiparesis or monoparesis, do you have any other differential diagnosis, Dr. Chaudhary?
Yes, hypoglycemia.
Excellent. Hypoglycemia, remember the thing, hypoglycemia can cause any neurological symptom. It will be correct. For any neurological syndrome, hypoglycemia is correct. So we can also say the other differential diagnosis as migraine. And if it's relapsing and remitting, we can also consider multiple sclerosis. So for transient limb weakness in one side, what are the differential diagnosis we are having? The transient ischemic attack, the hemiplegic migraine, which comes with headache, the hypoglycemia, and multiple sclerosis. And there is also a case which used to come in cases after performing some gymnastic work or hairdressing or some yoga session. patient develop right-sided weakness. Dr. Chaudhary, what's your diagnosis?
Coronary dissection. In that case, patient always complain for the neck pain.
Good. So you have to keep it in, differential diagnosis if you find this sort of history. So keep it in your mind that there is a possibility as well. Patient might have some form of dissection as well. But dissection patients are very critical. But they give this type of case in patients. Then the permanent weakness. So what are the differential diagnoses for permanent hemiparesis?
Permanent are the stroke with the first.
Permanent means we make this differential diagnosis for our benefit. It's not from book. It's for our benefit. Permanent means this weakness is patient still have weakness. Patient have weakness for last 4 hours, but patient still have weakness. We call it the permanent weakness. So this could be stroke. The number one, until proof otherwise, it could be stroke. So stroke. For stroke, in stroke, we should divide it into two parts: the younger stroke and the stroke in a elderly group. So for young stroke, what are the causes you will search for in a patient with young stroke? Suppose this case, in your case, this patient is only 26 years of age. What?
I would think about thrombophilia.
Thrombophilia, good. Vasculitis, good. Atrial fibrillation, good. Hemorrhagic stroke, good. Okay, so we discussed about the causes of younger stroke, and for other causes of permanent weakness, you also need to consider the demyelination and the space occupied lesion and infraction. So your differential diagnosis was not good. So I asked you that what's your differential diagnosis? You said me that you only say me that it's transient ischemic attack. So whenever you find, so what are the differential diagnosis of stroke?
I said my diagnosis was TIA, then stroke, and I said it could be hypokalemia and drug cause.
So hypokalemia.
Would
Hypokalemia.
not present in such way.
Yes. Hypokalemia could not. You can explain hemiparesis with hypokalemia. You can't. So for stroke, if you are totally blank in a neurostation, suppose you don't know what are the causes of sixth nerve palsy. So what are the causes of sixth nerve palsy?
The MS.
I tell you a trick. So whenever you don't know the cause of any neurological sign or syndrome, tell that it could be stroke, it could be infraction, it could be demyelination, it could be space occupied lesion, it could be infection. So what I say, stroke, that means infraction, demyelination, space occupied lesion, and infection. Infection means encephalitis, meningitis, HIV. Invariably cause any type of neurological thing, any type of. So we have infraction, that means stroke. We have demyelination, that means multiple sclerosis. We have infection, that means the HIV, meningitis, encephalitis. We have space occupied lesion. These are the differential diagnosis of any neurological syndrome. So if you said, yes, sir, I have some differential diagnosis, my most probable diagnosis is stroke, which can be either due to, if a patient, I want to tell you one more thing. If a patient presented to you with acute neurological symptom, like in this case, right-sided hemiparesis, you can't sure by only taking history whether it is ischemic stroke or hemorrhagic stroke. So you need to tell the whole thing to the patient and whole thing to the examiner, that it could be stroke, either hemorrhagic or ischemic, either ischemic or hemorrhagic. It could be space occupied lesion, It could be demyelination, like multiple sclerosis. And if they want to hear other thing, you can go for other thing. But these are the thing. You can also say the hypoglycemia as well. But it's very unlikely to be hypoglycemia persists for very at this period of time. So we discuss about the hemiparesis, the transient one and the permanent one. Now we are going for the paraparesis. Suppose this patient presented to you, Mr. Smith present to you with both lower limb weakness for last 7 days. And he developed his limb weakness after a marathon. After the marathon, he takes some rest, and after taking rest, he is not able to stand on his limb. So, Dr. Chaudhary, what's your diagnosis?
My first diagnosis is myopathy that could be due to electrolyte imbalance or any kind of glycogen storage disorder, myocardial disease, complex disease, and also hypokalemic periodic paralysis, and also thyroid oxygenesis periodic paralysis.
Okay, you said it all, but the rank of saying the differential diagnosis is not good, and sometimes number also depends on which rank you put which diagnosis. So it's most likely hypokalemic periodic paralysis, and myopathy for the first time is rare in thyrotoxic periodic paralysis. So for paraparesis, we have two forms of differential diagnosis. One is transient, same like hemiparesis. One have transient and one we have permanent. For transient limb weakness, we have two differential diagnoses. Number one is hypokalemic periodic paralysis. It usually happen after taking high carbohydrate diet or anything that provoked hypokalemia, like vigorous exercise. And this patient also have family history of such type of problem, and this patient it will not be his or her first experience. This patient will have several episodes of transient weakness. And for thyrotoxic periodic paralysis, you may get other features of thyrotoxicity as well. And now the second category, we have a permanent form of limb weakness. So suppose this is a 26-year-old school teacher who is Mrs. Smith, you can say. She presented with both lower limb weakness for last 7 days. What are your differential diagnosis, Dr. Chaudhary?
Can I take some history or without history?
What is your differential diagnosis?
Lower limb weakness, if it is ascending weakness, first I will think about AIDP or Guillain-Barré syndrome.
Good.
And
Good.
peripheral neuropathy.
Good.
Due to any cause such as B12, alcohol, or drugs.
Good. So
and also anterior spinal artery occlusion.
Okay, so for paraparesis, we are in the branch of paraparesis, and in the branch of paraparesis, we are in the sub branch of transient, and then we go into the sub branch of permanent paraparesis. So in the permanent paraparesis, there is a very important question. Remember this thing. So which part of your limb is weaker? For permanent paraparesis, you need to ask this question. This is the must question. Apart from this question, you can differentiate the diagnosis, the broad category of diagnosis, only based on this question. So we have to ask which part of the limb is more weaker. Is it your thigh or is it your feet? You got my question, Dr. Chaudhary?
Understood.
Very important question. You know it. How it's $1 million question. At which part of your limb you feel more weaker? They know it. I said you, this is a script-based exam. So they teach the surrogate. You will say, I feel more weaker on my feet. You have the diagnosis at that time. If they say, no, doctor, I have weakness in both of my limbs, both of my lower limb, but I have more weakness on my thighs. That's a whole different category of differential diagnosis. So if I say to you, doctor, I have weakness on my thigh, what's your differential diagnosis?
The proximal causes of the all proximal myopathy.
So for thigh weakness, we have proximal myopathies. So how you remember the proximal myopathies? I remember it by red CNS. Remember this thing until you pass the PACES exam. Red CNS. R stand for rheumatological. R stand for rheumatological. Most of the rheumatological condition will cause some form of myopathies, and that will come as proximal myopathy. Or in rheumatological condition, you used to prescribe which drug? The steroid. Steroid can cause proximal myopathy. Though, so in two ways, the rheumatological cause can present it with weakness, specifically weakness in the thigh. So how you manifest it? The surrogate will say you when you ask, so do you find it difficult to go up stairs? Yeah, doctor, you're right. I find it very difficult to go up stairs. It's very difficult for me to stand from sitting position. It's difficult for me to raise my hand above my head. It's difficult for me to comb my hair. These all are the quotient of proximal myopathy. So for proximal myopathy, I remember it as how? Red CNS, red CNS. So R stand for the rheumatological, E stand for the endocrine problem. So what endocrine problem we are having? It can be acromegaly, it can be thyroid problem. Both thyrotoxicosis and hypothyroidism can cause proximal myopathy. It can be Cushing syndrome. It can be drugs, as I said, the steroid, the statins, 2S, and the CNS. For the CNS, we have what CNS problem can cause proximal myopathy, doctor?
The myasthenia gravis and
Good, excellent. You can categorize these two disease, the myasthenia gravis and Lambert-Eaton myasthenic syndrome, into neuromuscular junction disorder. So what is stand for red CNS? The R stand for the rheumatological condition. The E stand for the endocrine condition like acromegaly, thyroid, and Cushing. And D stand for the drugs, and the CNS stand for the neuromuscular junction disorder, the Gravis, and the Lambert-Eaton.
I have one question.
Go on.
Can I add this electrolyte imbalance hypokalemia in case of proximal myopathy more in this part?
For hypokalemia, they will never give you the first episodes of hypokalemia. If they want to give you hypokalemic periodic paralysis, not hypokalemia, hypokalemic periodic paralysis, they need to give you some previous episode like this. And they will give you a very good family history. And when you ask the provocating factor like vigorous exercise, heavy food, high carbohydrate diet, they will pose it. They need to tell you something to reach the diagnosis. Remember this thing. They need to tell you something to to reach the diagnosis. So if you don't find anything in favor of that, there's not that diagnosis. So for hypokalemia, when you want to consider the hypokalemic periodic paralysis, so the first thing is it will fall into the category of transient weakness, not permanent weakness. Number one. Number two, it will not the first episode. There will be multiple episodes, previous multiple episodes. I hope you have the answer.
Understood. We have to differentiate the permanent and transit first.
Yeah. we divided it for our own benefits, not like book.
I asked that because Cushing syndrome always also causes hypokalemia, and I was thinking that primary hypoaldosteronism could be a possibility or not.
For Crohn's disease,
Yeah, primary hyper. Yes, I was thinking that.
don't think about Crohn's disease. For a hypertensive patient, you can consider, it's a separate category of disease, and this is not also very common in case of PACES exam. So we
Okay.
have we complete two categories of disease. Number one is hemiparesis, number two is paraparesis, and number three we said you that the number three we divided the weakness in another category. We call it limb weakness with back pain. Very common in PACES exam. I am telling you a scenario. Doctor, I am a 68 years old female. I'm a smoker, and my period monthly cycle was stopped about 10 years back. So recently I received some trauma on my back, and I think which developed after I tried to raise my back from the ground, and after that I developed some back pain, and in this back pain doesn't go away, and I heard from uh, one of my colleagues, let's say one of my colleague, that this could be a sign of cancer. What's your diagnosis?
Okay, first, I would ask for any kind of hospitalization, previous cancer or chemotherapy. If that is absent, then as he is in post-menopausal, it could be osteoporotic, vertebral fracture, and this is a traumatic.
Remember this thing, cancer is always a cover in basis exam. Cancer is always a cover, but it's a good cover because when you want to be a very safe doctor, you need to exclude the sinister cause. You need to exclude the red flag. In any patient who presented with back pain, any patient after 50 years, if you don't ask about, if you fail to ask about the red flag question of back pain, you will not pass the exam. You will not pass that exam in station. They will even cut down your mark in several other categories, like from history, from physical examination. So remember, back pain, red flag. Back pain means you have to ask about the red flag. So red flag, back pain, malignancy is a good cover. So in this case, it's likely osteoporotic vertebral fracture. This is very important. So this is a very common scenario as well. And so for other differential diagnosis you can consider in this patient, two, you said the uh, malignancy and the osteoporotic vertebral fracture. Any other thing?
Could be
Although it's not very common in cases, as
powder
this patient
ammonia.
as this patient have received some trauma, it could be musculoskeletal.
Mhm.
It could be musculoskeletal. And
I
if
would
you
ask any kind of sensation loss in the private part or not. Could I ask
okay,
that?
okay, good. If it is compressive, like neuropathy, if you're giving exam in Bangladesh, India, or Pakistan, they may give you compressive cord compression. So at that case, you also need to consider transverse myelitis, the tuberculosis, the spinal tumor as well. Good. So this is the whole part of approach of limb weakness. So Dr. Choudhury, what do you think? Isn't it very easy if we know how we categorize the symptoms and how we make the differential diagnosis?
Yes, it's very easy if we know the.
ঠিক আছে ঠিক আছে আচ্ছা না thanks. Okay, sorry for the interruption. So this is actually very important for every not only weakness. For every symptom, you need to develop a approach. How you develop an approach? How we will develop an approach? You will make an approach based on the common presentation in paces. Based on the common presentation in pace. So I recap the whole thing again. If you remember this thing, you will never miss a single case of weakness in your lifetime. At least you will reach the diagnosis. You can do mistake in examination or other part, but at least you will catch the diagnosis in very early part of your history taking. The first, whether it is unilateral or not. Is it hemiparesis? Yes, it's hemiparesis. Go to the wing of hemiparesis. Is it transient? Is it permanent? Is it transient? Is it TIA? Or is it hemiparesis hemiplegic migraine, which is very common in patients? Or is it hypoglycemia? Or is it multiple sclerosis? Or I also say to you another typical atypical case, which is carotid artery dissection. And for the permanent wing, we have stroke. And I also add another thing, we call it young stroke, where we need to exclude several other things to find out the cause of stroke in a young patient. We have infection, we have space occupied lesion, we have demyelination. For the wing of paraparesis, we have transient form of paraparesis. There's the hypokalemic periodic paralysis and the thyrotoxic periodic paralysis. And for the permanent paraparesis, we have we need to ask the question whether I feel more which part of my limb is more weaker. It's my feet or it's my thigh. If it is my feet, we ask about the motor neuropathies like you said acute myasthenic polyneuropathy, GBS. Other neuropathy like alcohol, vitamin B12 deficiency. Hello. Hello. Okay. For thigh weakness, I say to you that I remember is by red CNS, the rheumatological, the endocrine cause, the drug cause, and the CNS cause. And another category we have limb weakness with back pain, where we have several differential diagnoses. If it is cord compression, you can consider the trauma, the tumor, the spinal tumor, or metastatic tumor. You can consider the tuberculosis. You can also consider the transverse myelitis. So this was the case of stroke and limb weakness. And for history taking, your history taking was good. Apart from calling the patient elderly, don't say that patient is elderly. It's not a very pleasant thing for the British examiner. So if you say someone he is an elderly person, that's an insult. You can't. If you want to say someone is elderly in PACES exam, you can say senior citizen.
Okay.
You can't say old person. You can't say elderly person. You can comment like this. Some examiner may take it very negatively. So for history taking approach, how many are here now? Oh, we still have 12%. So these 12% are very lucky. So I will discuss about the history taking approach a short. So history, remember history is, there is no luck in history.
I have one question regarding my LCC.
Ask, please.
I stop after the CT scan. Do I have to just keep continuing that after CT scan we have to do MRI and then we have to do CT angiography to.
I got your question. I got your question.
Okay.
So we we don't deep dive into the management of stroke. That's a area examiner love to drive. So for a stroke patient, there are protocols. For a stroke patient, there are CT protocol and there are MRI protocol. In some NHS trust, go for the CT protocol, and some NHS trust go for the MRI protocol. By the stroke, I means the stroke, the patient who have weakness right now. Patient have weakness for last 3 hours and presented to the hospital with weakness. So if this patient come to me, what will I do first? I will examine the patient. I will confirm it's a stroke, and I will investigate the patient. Will you give antiplatelet just after thinking about a stroke? No. Why? Because as I said you, it could be hemorrhagic stroke or ischemic stroke. Unless you are doing a brain imaging, you cannot differentiate between hemorrhagic and stroke, hemorrhagic or ischemic stroke. So we need to take history and examination. We confirm our clinical suspicion. Yes, it could be stroke. We go for the brain imaging. For the brain imaging, we have two pathways. Even in UK, several trust follow the several categories. The one pathway we can do CT scan, and another pathway we can do brain MRI, including the DW sequence, diffuse weight sequence, DW sequence. So, what do you want to check in the CT scan, Dr. Chaudhary? What do you look in CT scan?
First, I want to look and for any kind of hemorrhage or any
Good.
kind of
This is the answer. This is the answer. End.
Okay.
This is the answer.
Okay.
If it is not hemorrhage, give the patient anticoagulant. Sorry, give the patient antiplatelet therapy. Give the patient loading dose of aspirin. And some NHS trust, after excluding hemorrhagic stroke, that's what's it indicate? It's ischemic stroke. After excluding hemorrhagic stroke, his patient have new onset right-sided hemiparesis for last 3 hours. What it indicates? It's ischemic stroke. And what happened? They directly give the thrombolytic therapy to the patient. Even now, the recent guideline says we can give thrombolytic therapy up to 6 hours. Up to 6 hours. Previously it was 4.5 hours, and some guidelines suggest we can give thrombolytic therapy up to 6 hours as well. And there is also an option for mechanical thrombectomy, which can be done up to 18 hours, or even some guidelines says up to 24 hours. So for the safe side, you can say 4.5 hours for thrombolysis and thrombectomy for 18 hours. And other wing, the DW MRI, the diffuse weight MRI. So in diffuse weight MRI, we will find diffuse weight MRI will get the brain imaging change within 30 minutes. Within 30 minutes. Do you know how much time it takes to appear finding in the CT in a patient with a stroke?
About 6 to 12 hours.
After 4 hours. After 4 hours. Okay. And for DW MRI, it will take just 30 minutes, even 10 minutes. Some say at least 30 minutes, or it may appear within 10 minutes as well. So what happened? You know, the NHS, they are very much concerned about their resource, the fair distribution of resources. So then don't want to loss of money by doing DW MRI to all the patients. Some trust make the protocol. If it is not hemorrhagic stroke, it definitely hemorrhagic stroke. So after excluding it's not hemorrhage, give thrombolytic therapy. No need to go for the DW MRI. And some trust, they're rich, they go for the DW MRI, they confirm the stroke location, they give the thrombolytic therapy. You got my point? But before brain imaging, don't give antiplatelet drugs.
Okay. So my question was, but I have to avoid saying this CT angiogram.
No need for CT angiogram unless it's hemorrhagic stroke. CT angiogram decision is not your. It will take by the neurosurgeon. What do you do with CT angiogram?
For thrombectomy, thrombectomy.
That will not your headache. So you will not go for the CT angiogram.
Okay, okay.
So in a MRI sequence, there are lots of sequences in MRI. So there is a MRA as well. So we usually in acute condition we will not, also not go for the CT angiogram. CT angiogram we need contrast and several other things. So unless this patient have some form of contraindication for brain MRI, contraindication for doing brain MRI like pacemaker, like some metal implant, at that condition we can go for the contrast enhanced CT angiogram. Apart from that, we have MRA, where we can see the vessel anatomy very well. And usually, if this type of decision will take by the neurosurgeons when the patient is a candidate for thrombectomy, mechanical thrombectomy, or the patient is having hemorrhagic stroke. They need to clip the vessel. Then they may go for, but that will not our subject. So, do you have any other question? We can go for the discussion about the pro forma of long case.
Yeah. My question is, as my patient was having stroke for last 8 hours, so was my decision correct to give aspirin?
Sorry.
My patient was having stroke-like symptoms for last 8 hours. Was my answer correct?
Yes. In a form that we will not go for thrombolytic therapy. We will not go for any thrombolytic therapy. In that case, after excluding the hemorrhagic stroke by doing a CT scan or preferably CT scan or DWMRI, you can give thrombolytic therapy. But after doing the brain scan,
Thank you.
you got my point. This is very important thing. This is a very important thing. Examiner know it and they will ask it. Will you give antiplatelet drugs by just clinical suspicion?
Never.
That it's a stroke? No. Because I don't know, sir, whether it's hemorrhagic stroke or ischemic stroke. After doing a brain imaging, after I confidently exclude it's not hemorrhagic stroke, I can give the antiplatelet drugs. So, for you, do you have any other question? Anyone?
Well, thank you. My question is finished.
Okay, you are welcome. So I many time I told about the approach of history taking, which is very important. History is not luck. Remember this thing. History is not luck. History means the long case is not luck. You have 15 minutes of time to think and reach your diagnosis and show the examiner that you are competent enough to deal with any case which is come with history and examination. So if you have a good protocol, if you have a good pro forma, or if you have a good format, there is a very high chance you will pass the consultation station with full mark. This is the less luck dependent station. Even the communication is luck dependent. You don't know what communication you will get. Even you getting the known communication, the surrogate may be not very good, or the examiner may be not very good, or examiner may not like the way you dealt with the concern of the patient. This thing can happen in clinical session. Bad luck is there. You don't know which case. You may forget to elicit important findings. But in history station, in a consultation station, it's totally depend on your competency, 100%. It's the ultimate judgment of your uh, of your level of preparation, how you prepared yourself. Because by the way you take history, I can tell you how long you been taking history and how long been practicing the consultation station. So by practicing the consultation station, you can tell me that after when I reach to the system analysis, uh, it's only go about 6 minutes. So other way of saying, I can complete the whole uh, 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 exploration of the history before going to the system analysis. It will require 6 minutes. So by doing lots of case with your partner or with your mentor, at some stage you will develop this competency that exactly on 8 minutes I complete my whole history, and within 8 minutes I go to the examination, and within the 10 minutes I will within 10 or 11 minutes I go to the concern of the patient. So you have to practice like this. Within 10 minutes you have to complete the whole history and summarize the history to the surrogate. So for history taking, we started our history taking by a good, very good introduction. So in medical life now, in every sector of our life, people will say you that your impression built on the first 7 seconds of the beginning part of the interaction. So when you enter the room, put a very big smile, like you are acting. You are acting so geniusly. Big smile on your face, but gentle, very gentle. You have to be very polite. Smile both of the examiner. Smile on the patient. Greet the patient. Touch the patient. Touch on the shoulder. If you are in Bangladesh, or if you are in India, or if you are in Pakistan, touch the patient. Hello, sir. How are you? That will give you a very, very good impression. You touch the patient shoulder. Touch the patient shoulder. So after that, introduce yourself. Hey, I am Dr. Hello, I am Dr. Hussein. I'm one of the doctor here today. And today we are here. What you are saying that today we are here to discuss about your health condition. And during our conversation, I may take some note, and I can reassure that our discussion will remain confidential. Is it okay for you, madam or sir? They will be very happy after listening that. Even the examiner will be very happy. It's a very organized candidate. So could you please tell me what brought you here today? Always try to ask the question, although you know that I am presented to you with right-sided weakness, but you make the very fast question very broadly. What brought you here today? And please don't interrupt the patient in fast 1 or 2 minutes. Please don't. And some examiner try to assess this thing as well. So you need to take your pencil and the paper. The exam sometime in Indian region or in Bangladesh or Pakistan, the surrogate are not very well trained. They memorize the symptoms, and when you ask what brought you here today, they will tell everything in one go in fast 2 minutes. So if you don't write it down, you will forget the important point. You will forget the important point. So don't break the eye contact with the surrogate. When the surrogate said, I have right-sided right hand weakness for last 8 hours, you just write R and 4H, and it's gradually increasing. Yes, you write down the upwards, the increasing sign. It's increasing, and then you say you also have weakness on your leg. Yes, I also have weakness on my leg. So like this, you can't stop the patient within uh, last 1 or 1.5 minutes. But if it is taking too much time, then you can interrupt. But at least give some time. And after listening to the history, patient may give you especially in Indian region and in our subcontinent, at the very beginning, they may give you concern. So after saying that, doctor, I have weakness on my right hand and my right leg, and I am thinking whether it's a stroke or not, or I am very frightened. And I heard that it's a sign of a stroke. So as as they given their one of their concern, you have to appreciate that. I understand you are very concerned whether it's a stroke or not. But before I commenting about the possibilities, I need to take the history and examination. But I can reassure that I am writing down that. So you have to acting like this. You have to write down in the paper that patient is concerned about stroke. So I am write it down, and I promise I will come back to this point at the later part of our discussion. So that will give you a mighty expression that you are a genius in communication. So you will not lose mark in concern, and you will not lose mark in communication as well. So you have to write that down. This patient having a patient is concerned, very concerned about, or just a few words, concern about stroke, concern stroke, and you can reassure the patient, sir, I will come back to this point at the later part of our discussion. Now come back to the history. So may I ask how long you've been having this weakness? So you can elaborate the weakness. Another thing is happen. So you have to make these scenarios in your mind. Anything can happen, but these things are common, and most likely 99% of the cases your registration will go like this. Sometimes this happen. Patient will say you 3 or 4 symptoms at a time. Yeah, doctor, I have weakness, I have headache, and I also have difficulty in swallowing. So what you will do at that moment? So you have to say, sir, can we discuss one by one? First, we can discuss about the weakness, then we can go for other symptoms. Is that okay for you? Yes. So could you please tell me about the weakness? Sir, you have to write down all the symptoms, but you have to start with the one. But this is a good thing. Why this is a good thing? If the patient said you 2 or 3 symptoms in one go, because it will help us to reach the diagnosis very earlier. With one symptom, it's difficult. With 2 symptoms, it will be very easy. With 3 symptoms, it will be like water. So more symptoms are good. So that, and I am telling you the symptom analysis. We have to explain the symptoms, and for the symptom analysis, after the symptom analysis, you need to, by doing the symptom analysis, you need to confirm the diagnosis. Suppose for chest pain, the symptom analysis, site, severity, nature, radiation, anything make it worse, anything make it better. You will have an idea whether it's ischemic chest pain or whether it is some other form of chest pain. Based on your diagnosis, you need to find out the cause. Suppose in this cases, so our case was stroke in an elderly patient. For elderly patient, stroke and heart attack, you need to ask about the all ischemic history, all the risk factor, hypertension, high blood pressure, smoking, hyperlipidemia. You need to ask that. You need to ask the complications, the complication of that disease. Like if you find a case of SLE, if you don't ask about the hematuria very earlier, you may forget to ask about the hematuria, or low amount of water work. So some disease you need to ask about the complication as well. So remember this thing. After symptom analysis, we try to find out the cause. Number 2 is the complication of that disease. Number 3 is the differential diagnosis of that disease. Suppose this is a case of a stroke. My one differential diagnosis was hemorrhagic stroke or space occupied lesion. So I need to ask about the headache. I can ask about the headache of raised intracranial pressure, like headache increase by coughing, sneezing, bending forward. And after the differential diagnosis, for the main symptoms or the main disease, we need to ask about the red flag. So remember this thing, CCDR. The first C is stand for the cause. The second C is for the complication. The D. So the D stand for the differential diagnosis, and the R stand for the red flag. And then you need to ask about the corresponding system analysis. So this is a case of stroke. So we will go for the neurological system analysis. So in neurological system, apart from weakness, we have many other things like seizure, confusion. So you need to ask about the headaches. So you need to ask about those things as well. After the corresponding system analysis, we will go for the PMF history. PMF history. So I tell you one thing, you need to follow what I am saying, or you need to make something better. So unless you make something better, you can follow what I follow. So I follow to take the PMF history. The P stand for the past medical condition, M stand for the medication, F stand for the family history. And in case of female patient, you need to add another P. So you all know, in case of female patient, we will need to ask 3 extra questions about monthly cycle, the period, the pill, and the pregnancy. The pill, period, and pregnancy. Then we need to go for the system analysis. System analysis, like just go through the system-wise analysis to ensure we are not missing anything. So you can say the surrogate. Now I am going to ask you some question that may not be directly related to your symptoms, but just to make sure we are not missing anything. And it's completely okay for me if you answer by yes or no. So you will rush it and screen the gastrointestinal system, screen the respiratory system, screen the urogenital system, the kidney system. So we need to screen the system. There is no need to deep dive on this. There is no importance of vigorously asking the urinary symptom in a patient with stroke. You know it. So we need to screen it very fast. Then we need to ask this, Dr. Chaudhuri, I think, asked this question very well. He asked about the mood. Remember this thing in history station, UK consultant specifically like this question, what about your mood? You can ask this question like this. Could you please describe your mood for last few days? Let me check how many of are you here. So you can take you can ask, could you please describe your mood for last few days? Yes, doctor, my mood is fine. No, doctor, my mood is not fine. So if you find someone mood is down, my mood is a bit down, you need to ask several other questions to evaluate the mood of the patient. So with the mood, you need to ask about the diet, you need to ask about the travel, you need to ask about the sexual history, if it is relevant. So remember this thing, like me, mood, diet, travel. Mood, diet, travel. Mood, diet, travel. Mood, diet, travel. All together. Mood, diet, travel. Could you please describe your mood for last few days? Do you follow any specific diet? Do you recently travel anywhere? Could you please describe your mood for last few days? Do you follow any specific diet? Do you recently travel anywhere? Most likely this question will be no, but this question have a weight. this question will give you a good impression. And sexual history, if it is appropriate, not like this. It's a case of 58 years old Mr. Smith who is having stroke-like syndrome. You are asking, evaluating sexual history. It's very inappropriate. So we will not go for the sexual history here. So if it is appropriate, you can go for the sexual history. For social history, what question we asked about the social history? Hello. Can anyone tell me what question we asked for social history? For social history, we ask 4 questions. We ask about the smoking, we ask about the driving, we ask about the living, we ask about the impact. Specifically chronic condition, for chronic condition, we need to ask about the impact. How much the symptoms affect your daily life? Remember this thing. For any chronic condition, you need to ask this question. How much this symptom affect your daily life or job? So first question for social history is smoking. The second question is driving. The third question is living. And the fourth question is impact. So have you ever been a smoker? No. Do you drink? No. What do you do for living? I'm a school teacher. How much this symptom affect your daily life and job? So these are the 4 questions for social history. For summarization, so I said you that you need to practice such a level that you need to develop a level of competency by the 8-minute, whatever the history, whatever the diagnosis, I can complete the history, whole history within 8 minutes. And at the 8 minute, I will summarize the thing to the surrogate. So I always tell my candidates, the PACES candidates, to summarize the case, because it will sound very soothing or very good to hear you are summarizing the whole things. And there is another benefit. When you summarize the thing, there is a very good chance surrogate may voluntarily use some other important information. So you can start by saying this: after talk to you, uh, uh, may I summarize the whole thing in few words, and if I miss anything, uh, I request you to add or modify things as you want. So you giving the surrogate a chance to modify anything or change anything. So you can summarize the whole thing in few words. So I understand that you've been having right-sided weakness for last 8 hours. You have more weakness on your hand, and you also develop weakness on your leg, and you said me that this weakness is increasing, and you have some other problems. Okay. Do you want to add anything? No, doctor, I don't want to add anything. Okay. So now I want to examine you. So after summarization, go for the examination in a relaxed mind. After summarization, you probably have 100% of your diagnosis in your mind. So one more mistake Dr. Chaudhary did. He asks very vague question at the end of the consultation station, which is not very good. Specifically, Indian examiners, they are not very friendly. If you ask about the vision problem at the do you have any vision problem, if it is your last question for in a long case station, in a clinical consultation station, they will carry a very bad impression for that specific station. So don't do it. So at the 9 minute, you are very confident, you did the summarization, you are very confident about your diagnosis, and you know exactly what you want to examine. If you don't know at that time, check the pulse for 10 seconds and recall the whole thing. Summarize what you collect the whole thing in your mind, what you want to examine in this patient. So I want to check the pronator drift, I want to check the elbow power, I want to check the pulse. I want to check the facial nerve. I want to check the carotid. I want to check the precordium very rapidly. I want to check the power in the lower leg. I want to check the plantar very rapidly. Sir, I want to complete my examination by checking the full set of cranial nerve examination. I have to check the blood pressure. I have to check the fundoscopy and other neurological examination, including the gait. This is the way to finish the examination. And after examination, you need to go for what do you need to go for? The concern. Concern. So at 11 or 12 minutes, you need to ask about the concern. And I always say to my to the candidate, I want to say the candidates that you need to ask concern for the 3 times. Remember, you need to ask concern for how many times? 3 times, because concern is very important. So ask about the concern. Ask about the concern 3 times. So, sir, do you have any concern? Yes. Why am I having right-sided weakness? What do you think, doctor? Okay, you write it down. I understand. May I ask, do you have any other concern? Yes, doctor. Is it stroke? Write it down. May I ask, do you have any other concern? No, doctor, I don't have any other concern. I am happy patient is not having any concern, any more concern. So what benefit it will give you when you try to meet one concern, you may forget to ask concern again. And usually in long station, the surrogate will have 2 or 3 concern. So you have to find out the all concern all together. And now you can say, sir, I understand your concern and I will meet your concern one by one. First you ask me that whether what's going on, what causing your right-sided weakness. So after talking to you and examining you, I believe you developed a condition we call mini stroke, or in a fancy term, as you said, transient ischemic attack. But don't bother yourself by the name. It's a very fancy term, which basically means some clot formation in the within the blood channel of our brain, and that hampers the blood flow in our brain, and that produce the symptom you are experiencing. And if the surrogate said you, is it a stroke, doctor? As I said you, it's a form of a stroke, but it's not a full-blown stroke. But at the same time, I can say you, it's a serious condition. We need to treat it promptly. You don't want to lose mark by saying vague things. You need to be very specific and you need to talk very maturely, because you need to show the examiner that you know your things. You are professional. So after explaining the thing, the 2 concern, you meeting the 2 concern, you need to do the other things. What other things you need to explain? I already explained the diagnosis. If you can't explain the diagnosis within the concern, you need to explain the diagnosis separately. So after meeting the concern, you can explain the diagnosis if it is not come within the range of the concern. So explain the diagnosis. If you don't have any specific diagnosis, you can explain after talk to you and examining you. Actually, I have several possibilities. Explain the most likely one. Explain the most likely one. After explaining the diagnosis, you can discharge the patient, or you can discharge the patient. So you need to formulate what this patient will do next, or what you will do next with this patient. So in the form of what you need to do, whether you need to do some investigation, any specialist involvement, must every case. You are a junior doctor, you are a You are a junior level doctor. So every case of the cases, you need to must involve the specialist. Must. This is a case of stroke. You need to involve the stroke team. Must. You need to involve the stroke specialist doctor as early as possible. You need to utter this word. You need to decide whether you need to keep this patient in observation or admission is needed. You need to decide this thing. And number 15 is a very important. Number 15 is very important. At the last number, you need to advise the patient about two things. What do you need to stop and what do you need to start? What do you need to stop and what do you need to start? Like in this case, Dr. Chaudhary did stop the driving, which is very good. Why? Driving. If you don't understand, sometime some patient have some symptoms like joint pain. Dr. Chaudhary, are you here? Or he left?
Yeah, I am here. I'm listening. My connection was absent for
Okay.
some time.
Suppose you find a patient who have joint pain and surrogates said you that his joint pain hampering his ability to drive. What will you do? Will you stop the driving or advise him to continue driving?
First, I will tell him that you should stop your driving and you
Good,
can
good,
inform the
good,
DVLA.
good, good. No need to inform the DVLA. Good. Answer is this. Remember this thing. Anything hamper the ability of driving. Anything hamper the ability of driving. Your answer was perfect. Until the time being, we are finding out what causing this problem. I strongly advise you not to drive. This is the ideal answer. So stop the driving. Stop the medication. Gout patient, thiazide started thiazide. You need to stop that. So remember the last point of the long clinical consultation is which? What I need to stop, what I need to start, what I need to stop, what I need to start. So you need to stop driving. You need to stop the drinking habit if you don't advise previously. You need to stop some medication like I said you the thiazide in a patient with gout. What do you need to start? If a patient is on pain, if some treatment you need to give very promptly, you tell the patient that yes, as you said, you have some pain. I will prescribe you some painkiller. So in this way, you can complete your total clinical consultation station. Remember this thing. I always uh, say all the candidates that it's all about acting. It's all about acting. You have to practice the acting, and mm, you have to do the overacting, above the surrogate, above the examiner, above anyone uh, in that room. Make that at a movie room and act. And how can you do the best acting? By practicing the acting uh, before appearing the real theater. So before appearing the real theater, practice and practice. There is no substitutes of practice in paces. The more you practice, the more confidence you will find yourself. So I hope this session give you some light about how to deal with weakness and mm, and how to approach and format our consultation station in a confident way and not weakness. Every symptom have this type of approach by which we can mm, reach the diagnosis very promptly. And one more thing I want to say you, the earlier you reach the diagnosis, the more confident you will feel in that station. It's very true. Remember that thing. The earlier you reach the diagnosis, the more confident you will have to deal with that station. So thank you very much. I have a uh, neurology clinical class tomorrow. Hopefully, I will take that class in. National Neuroscience Institute. So if you like to join, you can join. Hopefully, I can show you some good neurology cases. So thank you very much for participation.
Thank you, Bhaiya. Thank you very much for your time. I learned the most from you. Your class was very informative. Thank you very
Okay.
much.
Thank you very much. And if you have any other question, I am happy to take questions.
No
Any
problem.
questions you ask. So what problem here in PACES? Finding a, I always advise the candidate to.
Well, yeah, I during my LCC, which I just rushed to examination within 7 minutes. Do I have to follow every step and examine at 9 minutes, or I can do that?
No, 7 minute examination. So when you said, do you have any problem with the stand up? I thought that you will ask me to stand up and start walking. So not not like this. Uh, uh, you have to follow a standard protocol. You have to maintain your own format. That after summarization, I will do the examination. If you rush
Okay.
the examination part, you will miss lots of things. Remember,
Understood.
believe me for that, because you if you start 7 minute your examination at 7 minute, uh, you are missing the 2 minute part. In 2 minute you can take lots of more information from the patient and summarize the whole thing in your brain. When you summarize, it's also helpful for you. You will, it will direct you what exact thing you want to examine. So always try to summarize the thing, make yourself cool, calm, and then go for the examination. There is a very less chance to miss the vital things on examination.
Thank you.
Any more question? That was a very good question. Anyone can ask any question, even if you are new. If you want to take, if you want to ask in Bengali, মানে বাংলায় যদি কোশ্চেন করতে চান, সেটাও মানে গ্রহণযোগ্য। এখানে ই করার কিছু নাই, আপনি বাংলাও কোশ্চেন করতে পারেন যে
আপনি
আপনি।
কি ভাই জেনেসিসে কি রেগুলার আপনি এলসিসি কমিউনিকেশন ক্লাস করান?
এলসিসিটা আমরা এখানে তো মানে আমি চেষ্টা করব ক্লাস নেওয়ার আর কি, মানে ক্লিনিক্যাল ক্লাসগুলো চেষ্টা করবো নেওয়ার। কিন্তু আমাদের এখানে মেন্টরের ভাগ আছে, তো মানে কিছু ক্লাস হয়তো আদার মেন্টররা নেবেন, বাট চেষ্টা করবো ক্লাস নেওয়ার। আর কোনো কোশ্চেন আছে কি কারো? ঠিক আছে, তাহলে আজকের মতো থ্যাংক ইউ ভেরি মাচ এভরিওয়ান টু পার্টিসিপেট। অ্যান্ড আমার প্রফেসরের মতোই বলি যে পড়ানোর সুযোগ পাওয়াটাও অনেক আনন্দের একটা জিনিস। তো আপনারা যে থেকেছেন, আমাকে পড়ানোর মানে সুযোগ করে দিয়েছেন, এটার জন্য আপনাদেরকে ধন্যবাদ। আর যে কথাটা বললাম, সবসময় বেশি প্র্যাকটিস করার চেষ্টা করেন। যত প্র্যাকটিস করবেন আপনার কনফিডেন্ট মানে তত বাড়বে, এবং আপনি খুব সহজে বিনা টেনশনে বিনা প্রেসারে এসএস পাস করে যেতে পারবেন। ধন্যবাদ সবাইকে।